So this next section, I'll go ahead and pass over to Stacy to get started. Stacy?
So myself and then Shannon and Yvonne from TMA are going to talk for the better part of the next hour about kind of getting into the nuts and bolts around how we make telehealth work in practice. But before we get started, I just wanted to briefly mention, you've heard me talk about the Digital Health Implementation Playbook a couple of times. We launched our first playbook in this series focused on remote patient monitoring, and we're really excited to announce that we've officially completed the playbook that is focused completely on telehealth. And I was going to bring it up today, but for the sake of time, just thought I would mention it. You'll get a little bit of a teaser as I go through a couple of my slides here. But we do want we will be sending this out to this group immediately following the session today, giving you all kind of a sneak peek. You'll be the first one to see it in its entirety, but figured it would be very useful for this group to get as soon as possible. We do ask that this not be shared quite yet beyond this group. It will be making its formal debut publicly early next week. So we'll be sure to share the webpage and the download as soon as possible after that. But we will give you a hard copy or PDF copy. And then as soon as things open back up, the plan is to send kind of a nice book copy of this as well. So again, over the next hour, we're going to review some general considerations for designing your workflow and setting up telehealth in practice, including some specific policy, roles, and responsibilities across the practice and care team, and then additional, some state-based resources as well. And then we're also excited to have a few folks from different practices that are participating in the initiative to share some of their initial experiences implementing telehealth, since many of you have already gotten started. So we already have some kind of best practices to share from those participating in the group. All right, and I'll also note this information may not be as specific to the COVID situation, but still very relevant to what's going on today. We recognize, things are happening at a really rapid speed, as we heard from both Dr. Libby and Dr. Silva. But I think, it's also really important and really worth considering how we move forward with implementing telehealth now, but also later and into the future as well, and doing that in a thoughtful way to protect our patients, our practice, be able to tell quality stories, hopefully as well, to continue some of the coverage that we're seeing in this emergency situation. So to get started, we suggest, during this kind of step of designing your workflow, set some goals to accomplish. And in our research and talking to many physicians, members of the care team, even patients, how the workflow has impacted them, we've really identified some key goals to kind of set early on in the process of the work, designing the workflow. Help guide along the way. So I've kind of summarized a few of those. Getting input from both your care team members, others in your practice that are going to be supporting the telehealth program and visits, as well as some of the patients, would be really helpful as you start to think about what this means for your practice. So what are some of the physicians or the other clinicians that may be doing telehealth visits? What are some of their initial concerns or apprehensions? What are some of their preferences related to scheduling and things like that? And then also, do you know what times of the day are sometimes preferred by patients, right? So I think Dr. Libby talked about some after hours and things like that. So it's helpful to really kind of understand what you need from a clinician standpoint, but also what your patients will be looking for to help make this successful. And taking the time to document what your current workflow looks like and where that may differ in a telehealth visit is also really important. So then you can kind of start to map out what's needed from different care team members, how will they need to be trained, who needs to be trained, and considering things like scheduling and how medical assistants or nurses may interface with telehealth visits, how the front desk may check in or check out patients for telehealth visits. Clearly defining protocols for when a telehealth visit is appropriate. So how will this be incorporated into the scheduling flow? Is there a list of questions that your scheduler will ask patients when they call the office to kind of determine if they're appropriate for a telehealth visit or not? Or is this something that is, out on your website or in your patient portal that patients can kind of self-assess and would direct them to a telehealth visit? So just kind of identifying those protocols to be able to plug into the system or have for your schedulers early on is important. Realizing today, obviously, in the situation that we're in now, probably a lot more circumstances warrant a telehealth visit now than they would have maybe a month ago. You'll want to set up appropriate space in the clinic. Again, I know many of these telehealth visits are happening from physician homes today, but when you are in the clinic space, where will these visits be conducted? Is lighting good? Do you need any special equipment to be prepared in that room? Do you need dual screens, things like that? So really just kind of setting your space up for success too. And then a plan for scheduling, documenting, and billing for the visits. So when will telehealth visits be available, and how will you indicate those as time slots on the schedule so that the schedulers know when they can schedule telehealth visits? We've heard that it works for some folks as intermixed with other in-person visits, and then other physicians and clinicians have preferred to kind of have a block of time dedicated to virtual visits. So it seems to just depend on preference and how it works in your practice and what's best. What needs to be documented? So consent, notion of the virtual visit, things like that. Could these be created as new templates in your EHR so that it automatically pulls up kind of the inputs that you need to account for when you're doing a telehealth visit, and getting those set up in your EHR ahead of time? And then finally, ensuring that you know the right codes for telehealth visits and that those are actually integrated into your EHR and are able to be coded and billed as appropriate in the visit. So those are some kind of general considerations that we've created, but we've also broken down even further some key considerations for the pre-visit, the day of, and during the visit, and post-visit from real patient-specific, I think, perspective, I would call it. Shannon, one step back is fine. Thanks. Not quite there yet. So pre-visit, things like setting up triage protocols, like we already discussed, to identify patients that are appropriate for telehealth visit. Again, probably more of a past state or future state, given the current environment. Prepare and be able to distribute education materials on how to have a telehealth visit. So one of the resources that we've created in the Playbook is kind of like a patient-facing, here's what to expect, here's how to prepare for your telehealth visit. So really helping them be successful in their own homes or wherever they are taking that visit. How to communicate with patients. For example, visit reminders, how do you prompt them to initiate the visit through the platform, things like that. And then how will you check for insurance coverage for telehealth visits, or communicate any payment expectations to patients ahead of the visit. And then day of and during, this is kind of really the key pieces of getting your care team involved and who else will potentially be participating as a part of that televisit at any one point in time. So how do patients check in? How will you collect any payments or necessary co-pays? That could be, I know some platforms and vendors help to facilitate that, but could that also be done through your patient portal? Or any online kind of payment system that exists in your practice today? How are they kind of virtually roomed so that they're kind of in the space ready to be seen by the physician or the clinician? How will you consent, get the consent? Is that verbal and documented? Do you have an electronic form that they're able to kind of electronically sign? And then what does that handoff look like? Pre-physician visit and even post-physician visit. So what does what can the MA or the nurse potentially do before the physician is ready, and then after, if they need to communicate any next steps from a ordering perspective, if they are ordering prescriptions or things like that, if they need to schedule a follow-up time to come back, or is that via telehealth, is that in person? So kind of who's going to communicate that, or is that going to be the physician or the clinician that's taking the visit? And then some kind of post-visit considerations that we've mapped out. Some of the documentation may happen post-visit, some may not. So just kind of wrapping up that documentation. How will any feedback be collected from the patient? Many vendors, we've also heard, allow for kind of like a quick 2 or 3 question, questionnaire post-visit that the patient can kind of share what their experience was like very quickly, and that can help practices adjust in the future. And then ensure the bill goes out with correct coding, and then continuing to kind of track some of those reimbursements to make sure that if you are getting any denials or things like that, kind of troubleshooting that so that can be fixed for future visits and continue to bill correctly and collect the reimbursement. Next slide, please. So I've pulled out a sample workflow from Children's Hospital of Los Angeles. They shared this with us during our research for the Playbook. This is an established patient scheduling their first telehealth visit, and just kind of lays out the flow of the scheduling process. You can see then too, it lays out what happens the day of or during the visit, and really lays out who's responsible for each piece of this workflow. Of course, this will vary based on your practice staffing model, but I think this could be a very helpful guide as you start to kind of map out your own workflows and who's responsible for what pre, post, and during these visits. And I also believe Shannon and Yvonne will be talking in a little bit more detail about these roles and responsibilities across the practice as well. Next slide, please. We've also created a telehealth visit etiquette checklist. And we've put this together again based on what we've heard from physicians and care team members that we talked to from across the country during our research to create this playbook. And it covers considerations around environment, equipment, how to dress, communication tips for the visit. We know technology is providing, a really great option for seeing patients in a new way, but it definitely does have its unique needs to ensure that the visit is successful. So this is kind of the clinician side of the visit checklist and some key tips to consider. And again, we've also created something similar that would be patient-facing and educational in nature for them as well. Next slide, please. So it's also really important to plan how you'll tell patients and the community about your telehealth offerings, and really should be considered ASAP in this process, especially now. It will drive use, and it lets patients know that they can see their own physician via telehealth instead of potentially leveraging some of the direct-to-consumer options that often interrupt that continuity of care, which is a big reason, we've been, wanted to do the telehealth initiative in the first place, is really to help continue that continuity of care and allow patients to see you as their regular physicians in different ways. I wanted to specifically actually bring this up today because we've received quite a few inquiries and questions from physicians asking whether or not they're allowed to promote their telehealth offerings, because they had heard that these visits need to be patient initiated. So for clarity, we just kind of wanted to make sure that we let you know that there was no rule kind of prohibiting that proactive telling of patients about the telehealth offerings that you are now available to them in your practice. So we definitely encourage doing patient outreach, sharing communications on your patient portals and practice newsletters, kind of wherever you might advertise your practice. That will only help kind of let your current patients know that this is an option to them, as well as potential new patients too. And we do have some language in the resources section, again, of the playbook that practices can take and leverage for your own environment. But, really initial promotion can be as simple as just kind of an overview of the offering, what telehealth is, and maybe, some key pieces of information around what might be appropriate for a telehealth visit. So again, really just wanted to kind of reiterate that this is definitely something that you can do as a physician in a practice, and let your patients know that this is available to them moving forward. And then next slide, please. So there are some steps in the playbook between setting up your workflow and implementing. But given that many of you today participating are, on an expedited schedule and are probably in the midst of implementing, I just kind of wanted to touch on a few key aspects that we have in that particular step too, and that we think are really important. So I'm sure, everyone has encountered in the last few weeks, especially whether it's via the visits, the televisits you're already doing, or just having virtual meetings with folks that, technology can certainly have glitches. And it's, important to plan for these as much as possible. So, one of our suggestions has been to just kind of allow for some of that extra time in your schedule to kind of troubleshoot those, both either on your end or even the patient's end, maybe at the beginning of that visit, so that you don't kind of run behind, but you're really kind of baking that into your schedule for the day. We also, a few folks did this that we had talked to throughout the research process, but the idea of having these kind of quality checks on how telehealth visits are going seemed to be really important, and also kind of helped uncover kind of key issues or challenges that people were having and really troubleshoot those, and just also was a way to ensure the quality of the visit was happening, much like Dr. Silva said, kind of, while there's a lot of expansions and restrictions being lifted, we still want to make sure that we're providing quality visits to patients through this mode of the visit. So we kind of have heard that doing quality checks as a team, so if you have multiple colleagues or staff members or physicians and clinicians that are participating in this kind of once a week or every other week now, kind of checking in, almost like a rounds, grand rounds type of thing, talk about what's going well, what's not, maybe pick a visit that went exceptionally well and maybe one that didn't go so well, and try to use those as ways to kind of troubleshoot and make sure that, the telehealth program is providing the quality of patient care and things like that you need. And then the last key kind of piece here is to track some of the metrics that you and your practice would consider measures of success. Your measure may look a little bit different now than it would have been pre-COVID, but I think we all recognize the impact of telehealth and how it can be a really positive experience for both patients and physicians. You all signed up to participate in this even pre-COVID, so there is that commitment there. But I think it will be more important than ever now that we have this group having it already established, to really surface the success stories that come from this, surface the positive outcomes and data that come from this, much like Dr. Silva and Dr. Libby have said, to really kind of be able to tell that story of the impact telehealth can have for the future, so that, when we do get past this time and we return to that normal space, hopefully we can keep many of these coverage expansions and things like that in place to continue to provide these services to patients as well. So I will stop there and transition over to TMA, and then I'm sure we'll be taking some questions after.
All right, thank you, Stacy. Excellent information. I did want to go back and share just a few slides on some data that TMA has collected. We did a survey in January, and this was pre-COVID, of telemedicine use, and I thought you would be interested to see some of the results about how physicians are using telehealth. Now, mind you, this was just in January, so how telemedicine is being used. how it's anticipated to be used in 5 years, which I think just a couple of months later, we are seeing some of those numbers, which I'll show you in a second. And then what are the barriers? And the top two being the technology hassles and the no or low payment. So we're seeing a lot of that addressed right now. And then, as you may, well, at least in Texas, it is required that if you have a direct-to-consumer telemedicine visit, that the primary care physician should receive the follow-up documentation of that visit. And we're seeing that only about 15% are seeing that documentation. Now I want to show you, and this is just really hot off the press, and this information, we did a survey this week. We've had over 3,500 physicians respond to it with a 9.5% response rate. And we asked them about telemedicine, but one of the first questions was operational challenges for physicians, and one was identifying telemedicine as far as getting started, problems, and even payment problems. 44% said that was an operational challenge. And then we see, as far as plan to currently offer telemedicine at the practice, 56% said yes, regardless of compensation. That shows the compassionate care that physicians provide, that physicians know it's time to step up. And then 23% said yes if compensated appropriately, with high recognition of the viability of their practice, that physicians should be paid for the work that they do. 12% saying no, 7% still weren't sure. And then I thought question 7 was interesting, needing assistance getting started with telemedicine. 70% said no, they're already are jumping in and doing it. 20% said yes, and then another 10% did not know. And then reason for not offering, and this would be of only those that said no, so that would be the 12% here, of the 12% that said they were not going to do it, and 56% of those said they don't have the capable technology, or that the patients do not. So I just wanted to share that data with you as far as where we are with telemedicine. We have seen that a lot of times when we have surveys and such of our Texas physicians, that the numbers typically trend at the national level. So I did think that was interesting. I want to transition now to just showing you some things that we do have on the TMA website. And this information we have fully available, full access for all physicians, for anybody, anywhere. And we have been filling this out quite robustly over the last few weeks. A few things I wanted to point out are we have the Telemedicine Policies and Procedures. And Yvonne, my colleague who is on with me today, we're going to go over just a few of these, but it's in this section on our website, which is simply texmed.org/telemedicine. All of these policies and procedures, and I'm going to open just this first one, administration and billing. And I want you to see that these are all in Word documents, so you can take them and you can adapt them to your practice however you need to. And so we have this information in here. You're welcome to take this, adapt it as needed. If you would like to add your practice logo to it, that is perfectly appropriate. Yvonne, do you want to take a second if I go back and just scroll through these, and do you want to say a few words about some of them? Are there any additional ones you'd like to open up?
Not necessarily open them, but Shannon, you're not sharing the actual document on the screen. You have to go back to share screen and choose it. Showing the website, so they haven't seen the document itself yet.
Okay, so if I stop share and then go to it and share again, does that show it now?
Yes, there you go. Okay.
Thank you.
Good. So I'll talk through that. So each of these is created with in the same format where you'll have a purpose, policy, and procedure. And the purpose just explains why it exists. What's the point? The policy explains kind of like the brief statement of this is how things will be done, and according to whomever. And then your procedure really is that step-by-step process. So when Stacy was talking earlier about developing protocols, this is where they actually get documented. You really need to write those protocols down step by step. And the policies and procedures help you for a number of reasons. One, it helps you to really nail down your workflow and think about it step by step. It also helps you develop an actual orientation training tool for your staff to use. Or in the very beginning of the process, once everybody's been trained on the protocols and maybe somebody forgets something, they can go back to that document and go, oh, okay, that's what I have to do in that part of the process. That way, everybody in your practice is on the same page. Everybody is doing the same thing all the time. So you have consistency in your processes. And then last but not least, which is something that we tend to not really think about because fortunately it doesn't affect us all in our daily practice. But when it does affect you, it's huge. And that's the risk management piece. It's really very important that you have policies written, procedures written, that your staff is trained on those policies and procedures, that they're following those policies and procedures, because if something does happen and a patient were to bring some type of lawsuit forward, you're able to say at that point, we followed policy, we followed procedure. It's kind of your backup. So you'll see as Shannon's going through there, some policies that are more clerical and clinical, and clerical and administrative, that have to do with things like billing and scheduling and things of that nature. And then you'll see there are also some that are a little more related to clinical functions, such as who you're selecting, what type of conditions you're selecting for telemedicine, which kinds of patients or types of conditions are appropriate for televisits, how you're going to deal with prescribing medication management and things of that nature. And then, of course, there's also provider-to-provider communication. Lower down there, you'll see, similar to what Stacy was talking about with some of those patient-facing forms and physician-facing forms, we have some of those quick reference charts for payers, not for payers, but about payers, really. And then a quick reference sheet for patients. That would be a template, something that you could customize, just as you can customize all of these policies and procedures. But even with the quick reference sheets, you could customize that to your process, to your technology, to whatever. And that's a document or a flyer, pamphlet, if you will, that you can give to your patient when you're talking to them about telemedicine in your practice. There's also a quick reference sheet for your practices. These are things that, again, people that are involved in the process of telemedicine in your practice can use if they need a quick reference to remember how to do something or what to do about a certain situation. And so, again, you want to customize that to make it relevant to your practice. And then just some other types of forms. And again, they're in Word documents. More than likely, you would put these in some type of digital format, whether it be on your whether it's on like a shared drive or whether it's on your EMR or your telemedicine platform, or on your patient portal or your website. So just some things to think about in terms of information gathering, whether that's from your patients or keeping a log of your referrals, things of that nature. So that's what's on that page. And it is, as Shannon said, all in Word documents, publicly available at textmed.org/telemedicine or /telemedicine, sorry. Is that a backslash? I can't ever remember.
Yeah, /.
/ there you go.
Thank you, Yvonne.
Mm-hmm.
And then do you want to talk briefly about the roles and responsibilities within the practice?
Yes, and if you'll let me, I'll share my screen here. Let's see. All right, I think that's the one. All right, can everybody see that?
Yes, looks good.
Marvelous. Okay, so there are roles and responsibilities are important in a couple of different areas of your telemedicine process or implementation thereof. So you've got the beginning phases, and Stacy touched on this a little bit, where you have those first steps where you're doing all of your planning and all of your pre-work to implement your telemedicine. So just some things about who needs to be involved in those. You know, in that first step, you're trying to define what your needed services are, where's your gap. This would be really anybody in your practice would be involved, but you need some folks that are willing to take ownership of the project. That might be your providers. You might have a provider champion on staff or your practice administrator. There may be even your staff members that can tell you, your clinical staff, your scheduling staff, those folks can tell you where those gaps are and help you see where there might be some needs for telemedicine service. Then in your organization and your readiness assessment, you need to determine who is interested and willing to provide telemedicine in your practice. Do you have ancillary support services like registered dietitians and LCSWs doing behavioral health? Are your NPs, PAs going to be doing telemedicine? So you want to think about who's all going to be involved and who's going to be interested in using it. And then again, you want champions in each of those areas of your staff, of your organization, that will help the rest of their folks in their department come alongside. And then when you get to the point where you're choosing your platform, looking at your equipment, acquiring equipment and things of that nature, who will be using that equipment? And where in the office will they be located when they're using that equipment? Do you need tablets that are mobile? Do you need laptops? Do you have video equipment that's appropriate? If you're in a situation where you're having to look at maybe, you need some high definition video quality for skin lesions or something of that nature, how is that equipment going to be used and who is going to be using it? And who is going to be responsible for really understanding all of the IT pieces and managing the troubleshooting, that type of thing. And then when you get down to the paperwork and policies and procedures, who's going to take care of any licensing and credentialing that you might have to do with, if you have private payers that want to see specific documents and have those included, who's going to be responsible for that type of thing, and who's going to take responsibility for drafting and customizing those policies and procedures. Then you get down to your workflow. And this is where you're at the point of implementing and you're deciding on those protocols that Stacy was talking about. Your front desk staff, your clerical staff can deal with scheduling. They can also assist with educating your patients on the availability of the telemedicine, helping them, giving them the proper links, whether that's via email or whether it's in a pamphlet, something like that. And then, of course, are involved with payment collection potentially. And again, some of these roles and responsibilities will be dictated by the technology you're using, how those platforms are set up. So just keep that in mind, that the point is you want to be flexible and creative. Your clinical staff, they can do some pre-visit work with patients, like Stacy was referring to earlier, or you can have them start the telemedicine visits and do that med reconciliation and reason for visit history. You can also include that information on a patient portal, if you're using a patient portal, and have patients go in and do that information ahead of time. Again, how you develop that workflow and who's involved will depend on the technology you're using. Your medical assistants can do some patient education following a telemedicine visit. If you've gone over something with your patient, you can hand it off to an MA, a nurse, or whomever to complete patient education, so that you can move on to see the next patient, whether that's a virtual patient or an in-person patient. Your clinical staff can also be taught how to schedule the visits so that once they finish with the patient, providing any type of instructions or whatever, they can schedule their follow-up visit right then and there. And then lastly, your business office staff, they can certainly have a role, an appropriate role in doing insurance verification and investigating coverage of telemedicine services. Because it is at this point in time, hopefully this will get better in the future. But with private payers in particular, it can vary from one payer to the next. And then you've got employer-sponsored plans, and it just can be just such a range of coverage. So having your billing office do some of that footwork will help make sure you're getting paid for your visits. And they can also provide patient education of the availability of telemedicine and the telemedicine coverage. They can stay up to date on the coding and dealing with the appropriate billing mechanisms and things. And then they can also be a part of payment collection. Perhaps they provide some of that service up front before the visit starts rather than your front desk people. Just again, depends on your complement of staff, the amount of staff you have, and the technology you're using. And that's all I have. Thank you. And I need to stop sharing. There we go.
Thanks, Yvonne. Excellent information. And thank you for your work on those policies and procedures. Yvonne is the brainchild behind those and spent a lot of time developing those. So thank you for your work on that. We will all benefit. I want to now, we have some time left, and I know that there are still questions coming through, but wanted to get just a few words from physicians in the trenches over their experience in the last week. And Dr. Valenti, I would love to call on you just to tell us briefly how it's been for you over the last few weeks.
Hey there. First of all, thanks everyone for being on. Last few weeks have been very interesting, trying to coordinate patient visits and then putting off patients who are having surgery, especially patients who are having a lot of pain and who want surgery. The Texas Medical Board came out last night with an indication that they would not only will pursue doctors doing anything elective or what they consider elective, but now the doctor only has 7 days to respond to a complaint instead of 28 days. So they're really, really coming down super hard here. I have a patient currently that has a lot of pain, but the hospitals told me no. And so now it's pain management, but at least we can do that with the new guidelines. We can prescribe opioids without having a patient visit, which is a relaxation. One thing I'm noting is that visits are extended a bit because with almost every patient we're asking about COVID. So, that there is a code, a screening code for encounter to discuss COVID. There is a ICD code, I should say, for that. And so I'm including that on a lot of my visits. And interestingly, even on some visits where they would be no pay visits, like a post-operative visit, if I spend more than 50% of the time discussing COVID, that then becomes a paid visit. So that's something to be aware of as well. I know everyone's looking for some tips and tricks as we're all trying to stay afloat here. So trying to do that with some of my patients, or really they're initiating it, is a big one. We have Helo Agent through HCA, and that has actually been extremely smooth. There's almost no learning curve. We're doing both phone and telehealth visits without any difficulty. We have templates built in that the MAs put in. Medical assistants do all the history and everything ahead of time. We just go ahead and confirm that when we speak to the patient. I am able to glean a lot of things on the physical exam visually. For my postoperative patients, I am able to look at incisions and even share with them their laparoscopic photos by sort of holding them up to the video and going, here's your tube, here's your ovary, So we're able to do that sort of stuff visually, and patients are okay with that. I think patients are generally pretty happy with how things are going, and I think they're also happy that we are very concerned about their ongoing health, especially with the COVID questions, in addition to the standard questions. So not much issue with that. We're not sure about payment equity for nurse practitioners and certified nurse midwives, and maybe I'll let someone else chime in on that, because we are still doing OB. We're doing drive-up OB visits now, where you stay in your car and we'll come out outside the building and listen to fetal heart tones and do measurements. We're doing vaccinations and immunizations outside. So the nurse is coming out to give you your Depo-Provera or your Gardasil or whatever it is. So we're adapting. But I think really it's people have been pretty flexible about how it's working. And I think they're just happy to have any care at all right now and have access to their physician. So I would say Dr. Libby has been quite prophetic about the need for this, as well as physician wellness and moral injury is obviously another big topic. It's not what this is about, but he's been very leadership driven on both of these issues. So way to go, Russ. But at TMA, I think we're doing a good job. And of course, I'll be bringing, as your board of trustee member from TMA, I will be bringing all of this information to the board of trustee meeting tomorrow when we have a Zoom meeting. We're having a meeting once a week. So we'll be talking about that as well tomorrow. So thanks for the chance to chime in.
Thank you, Dr. Valente. Dr. Howard from Florida, would you like to say a few words?
Sure. Thank you very much. First of all, this is a great conference so far. Appreciate it. I'm a huge fan of telehealth and been for a very long time. And my practice may be a little bit different, solo practice setting, mostly a hybrid type practice. So I take insurance and also have some subcontracts as well with patients. And this has been incredible. I basically was able to go from seeing patients in my office to 100% online without any difficulty. Even my 92-year-old patients get on. For those who absolutely can't, I use whatever they can, telephone or even just email if I have to, or I will see a few people. But this is an incredible thing. I think the most important point to really understand about this is an opportunity for physicians to really engage the patients in helping them understand how great this is for them from a time standpoint and many others. And I think it's maybe one of the few things that we can do to get patients on our side to discuss with legislators so that this is something that stays where it's at. I don't want to see any decrease in value. I mean, physicians have a tendency to overthink everything. And so I think we have to keep it very simple. We have to absolutely have it so that, we are paid at the same par rate. In my practice, what I do is maybe different than other people, but I spend 30 minutes with every single patient at a minimum and an hour for new patients. I see new patients. I was a board certified gastroenterologist. I'm an internist. I do many other things. And so I pull in whatever tools necessary at the time that I'm talking to them. And I think that there's going to be great utility for this moving forward. It also can't be everything for everybody. I hear some questions about physical exam and other things. And yeah, great. I mean, technology in the future is going to enhance that. And there are already some devices. But being able to touch a patient in certain things that we have to do, acute diseases and things like that are still going to need to be there. So it's going to be a hybrid between what telehealth could be and more. I think it also increases the communication with patients, which is really the thing that breaks down care the most. And therefore, being able to communicate and get paid for it is going to be the biggest thing that can happen to medicine in the future, no matter whatever else happens. So this has been extremely helpful. The coding part is still a question. There's, even as I mentioned that, even in the booklet on page 102, there's a question of which code you're using, 11 or point of service 2, which is what I do. I've been paid at 100% the rate that I've been paid previous using that methodology. And we'll see how it goes. Obviously, our state payers we're working on, and we need probably more simplicity nationwide for that. The last part is looking at crossing state lines. Right now it's very lax. We have to see how to put that genie back in the bottle and national licensure and other things like that. So that it opens up other issues to discuss. But overall, it's been extremely helpful. The last thing is everybody has an electronic medical record. I don't really feel like paying extra fees to use their clunky system. Basically, it should just be a user interface, a bidirectional user interface between a patient that's HIPAA compliant. Obviously, Apple hasn't signed the BAA, so the question is whether or not they will or not, which would make it much easier for everybody because that's a usable platform. But for now, I think the most important thing is maintaining connection with the patients, finding ways to get paid for it and continue paid for it, and making sure it doesn't go away. And I think the only way that we do that is by engaging the public. Because the physician voice alone doesn't generally get it done. So thank you.
Thank you, Dr. Howard. Excellent feedback. And then Dr. Atkinson from Massachusetts, would you like to say a few words about your experience?
Sorry, one more time, please.
Dr. Atkinson, Massachusetts.
I think Dr. Atkinson's mic is off. Is Dr. Jepson on?
I can unmute Dr. Atkinson if I can find her. I saw her earlier.
Yes, Dr. Jefferson is here. Can you hear me?
Yes, please go ahead. Thank you.
Well, our experience in the office has I think, been very good so far. We're still trying to figure things out in terms of process in the office. We've settled on DoxyMe clinic version for now. We are using FaceTime when patients have an Apple iPhone. We find that easier. We've had some glitches with DoxyMe. For some reason, it just suddenly turns off, and then we've had to get back on. The other day, we started with our office manager initiating the visit on DoxyMe, and then transitioning over to our medical assistant to do a medication reconciliation and other things, and then transitioning to me. We seem to be figuring out a process. We have a lot going on, obviously, in this environment right now, but we seem to be doing pretty well. I think our telemedicine visits range from 8 a day to maybe 16 this week.
Dr. Atkinson, I see your mic is now off if you want to add a few words. Thank you.
Yes, thank you. When this first started, I actually contacted our legislators. Can you all hear me? They were really proactive and went to, so it was the leadership from our Mass Medical Society and 2 of our local legislators went to the governor's office, who immediately made a decree stating that all telemed visits, including telephone calls, needed to be covered with no out-of-pocket expenses for patients, including co-pays and deductibles. That was huge and was started really early before most of the doctors in our area were using telemed. So I feel like big kudos to the MMS legislative staff and our government for taking that on. We've still had to hold some of their feet to the fire on this. Some of the insurance companies wanted to only pay for COVID visits by telemedicine, but we insisted that seeing patients by telemed visit, keeping them out of the ER for any reason was worth it, and most of them have gone along. So that's been a big plus for us. We've actually put in place some processes that have made things easy. Initially, what we did was we sent our one pregnant provider home and had her do all the telemed visits. And she found it was a ton of work because we were used to having our clinical staff room the patient, get at the history and everything. So we then changed the process so that our clinical staff call every patient and pre-screen. We get their medications, ask them to get their blood pressure, their blood sugar. We even now have them screening things that we would normally do in the office. For instance, a follow-up ADHD visit, we have them fill out the ADHD screening form or tell the peak flows, that type of thing. And we've now taken it one step further where we now have a clinical staff person sitting next to the receptionist. The receptionist books the visit, then the clinical staff person does the pre-screening. Because we have almost no patients in our office. We went from seeing about 300 patients in a day in our office to about 2. So our clinical staff were bored, and this is working really well. I think those are my pearls. Thank you.
All right, thank you. Meg, do we want to take maybe just 1 or 2 questions before we close out the day?
Yeah, I think that sounds great. Oh, I'm echoing a little, but One question that I see still seems unanswered is Keeling was wondering if anyone has been seeing or using any patient satisfaction surveys like specific to telehealth.
So Meg, I'll weigh in here on that. We actually do have a sample one within the playbook that we've put together 5 questions, obviously not embedded into any existing survey right now, but certainly, something that you can use, whether it's just emailing it to them after based on, the situation that you have in your own practice. But we do have kind of a downloadable tool related to patient satisfaction. And then I did want to just quickly touch on Dr. Howard's mention of the code in the playbook as well. On our navigating, coding, and payment resource within the playbook, we did make the decision to keep that specific to pre-COVID, just in case all of these changes are rolled back. So that is pre-COVID. However, there is a little author's note you'll see at the top of that resource that actually links you to the quick guide that we developed, which is the kind of a very truncated version of the playbook with the latest updates with all of the codes and payment processes right now. And we fully intend to kind of revisit and make updates to the playbook after in the months to come, recognizing that as an industry, we're learning so much right now, and we're very hopeful that some of these expansions, in fact, do stick around, and then we'll be able to make those adjustments then. So just wanted to kind of touch on that too, because I saw that in the chat box as well.
Great. Thanks, Stacy. One other question was related to just clarification for whether nurses and case managers can, bill, especially without a provider visit. So Dr. Silva, would you mind commenting on that?
Yeah, I'm glad to do my best. So there was some language in the interim final rule that was specific to supervision. So for example, one of the laxities that was provided was in the hospital where the previous requirement was that a physician had to be supervising the patient. Now that requirement has been waived. There's some changes regarding direct supervision versus general supervision, and they've sort of lessened those also. And then lastly, there's some language about incident to types of services where previously the physician would potentially have been able to bill those, and now those requirements have been changed. So if the physician's not directly involved, they can still bill. I don't want to comment too specifically beyond that because I'm still actually, frankly, still dissecting that part of the rule. Yeah. But I do think it's an important question for us to put on the books to try to answer pretty quickly, Meg.
Yeah, great. For purposes of time, I think a lot of the other things, can be slightly additional clarifications as we go here. But as Bridget and team noted, we're planning to aggregate all of the key comments and questions from this, and we'll be following up, as well as sharing out the recording from the day. But, on my behalf and on behalf of AMA, can't thank you enough for all the work that you're doing on the front lines right now. And just to let you know that we're here for, anything that you need. And please feel free to reach out to any of us directly with any questions as things go. And we're really looking forward to continuing the telehealth initiative, and just thank you for all the work that you're doing.
Thank you, Meg. With that, I would just like to say, as far as next steps, we do have our next webinar scheduled for April 23rd, Thursday, April 23rd, entitled Redesigning Your Practice. And I realize there's a lot going on now around COVID, but we do need to keep our eye on the long-term vision so that once all of this is over and some of the regs are rolled back, that we do have the right things in place when we get back to whatever our normal will be. And then also a reminder that we still will do an in-person meeting on August 28th and 29th in Austin. We will take a little bit of a different focus because I think at that point we can look back on these experiences over these last few months at that point and look at how we can refine how telehealth is used within the practices. So please make sure that's on your calendar at that time. As far as CME, again, this was approved for 2.5 hours of CME. For each of the states, if you will let your state lead know that you participated, it is for those that participated live. We will have a recording of this preserved. I have to confess that I started the recording about 13 minutes in, so a little bit of it we did miss, so my apologies for that, but we started it as we were starting with Dr. Libby's presentation, so the meat of the program is there. Thank you. I know you are all so busy, so thank you for the time you devoted this morning to this, and we are available to answer additional questions as you think of them, put it out to all of our experts to help as much as we can. And with that, we will conclude the meeting and have a great rest of your weekend. Thanks again. Bye, everybody.